All right. Hello and welcome. My name is Garrett Hollenbeek, infection preventionist with Bon Secours Mercy Health. Welcome to our first episode of Hygiene Huddle, where we get the hot takes from the topics of concern by a panel of bona fide experts. So we're going to huddle up here and we're going to have our panelists introduce themselves and then jump right into the topic. So Jill, we'll start with you.
Hey everybody, I'm Jill Holdsworth, Infection Prevention Manager at Emory University Hospital Midtown in Atlanta, Georgia. Happy to be here. Thanks.
Deanna, you want to jump in next?
Yeah, of course. My name is Deanna Hillstrom. I'm an Infection Prevention Manager in Winston-Salem, North Carolina, working for Novant, and I'm happy to be here as well.
And that leaves you, Trina.
I'm Trina Illingworth. I have Longmont United Hospital in Longmont, Colorado, and St. Elizabeth Hospital in Fort Morgan, which is a pretty rural hospital. And I'm the Infection Prevention Program Manager for both.
Awesome. So we've got a pretty wide array of expertise here. The first topic that I think everybody has to tackle in infection prevention is how to address non-compliance with hand hygiene and PPE. So you're rounding and you see the doctor that's been there for 20 years go into a C. diff contact room, no gown, no PPE. We've never seen that before. But how do you address non-compliance with hand hygiene and PPE? And Deanna, we're going to throw this one out to you first.
Oh boy, we're starting with the doctors.
Or
No,
anybody. It could be anybody.
No, I think this is unfortunately something that we see quite common in healthcare. I think it's, in fact, I actually can say I saw the exact same scenario described today when I was walking through one of the units. And I think it's important that we stop at the education and the why. What I'm finding when I'm on the units versus just saying, hey, you need to do this. If I really stop to explain the reason for why we're saying it, it's not just like, especially for those precautions, it's not just for themselves, but it's for that next patient they're seeing. It's for that 1-year-old baby that they have at home that you don't want to bring it to. And so it's a lot of bringing it back to their, like, not to their level, but more of just helping them to understand it has been very successful in getting them more on board.
Yeah, 100%. Trina, have you ever seen a particularly good instance where somebody, you had to kind of ding them on hand hygiene or PPE and had a good outcome with it?
Yeah, I used to be a health inspector, actually. So it was my job to be kind of confrontational and to stop, potential infection issues, when I see them, and to educate and to sometimes coach. Sometimes English isn't the first language from my previous jobs. Obviously here at the hospital is a little bit easier. So I do speak some Spanish, so I would translate, best I could, model, demonstrate what needed to be done, and then coach them through to help them remember, because behavior is really hard to change. And sometimes you need a little extra help so you can relearn that behavior and to make it solid. So I agree with what Deanna said as well. As I usually introduce myself, note that there's an issue there, and then educate them on the correct way to do it.
That is great. I think introducing yourself, that makes a big difference right there. When you say, hey, I'm the infection preventionist, I don't know if I've met you,
Right.
And Jill, what do we do, or what have you done when it's just the same, let's say it's the same person, just every day, every week, you may see them and they're not great with hand hygiene. What have you found to be successful?
One thing that I have found successful, not just explaining the why, that I think that kind of is step 2, but also asking them what their perception of what's supposed to happen is. And I have gotten some really great insight when just trying to figure out what is your impression of compliance. And that actually is quite insightful and really gets to the root of what you have to work on. If they don't even understand that they're supposed to use soap and water in this instance, or that they're supposed to use hand gel even when going into an unoccupied room, or they don't even know what the hand hygiene policy says, then that's where your problem is. So you can't just go up to them and start talking about, we have to do this because it's the best for our patients, you actually have to figure out what is making them continue to be non-compliant, because they may in their head think that they're compliant and think that they're doing amazing. And the same goes with the physicians. We have found that they don't wear the PPE, or they're not doing something because they truly think that they're doing the right thing. And until you actually ask them or have a conversation with them, instead of just, you can't just mark them non-compliant on your audit sheet and walk away. You really have to start learning to get comfortable with engaging in conversation, which as new IPs, I can remember being very uncomfortable with that. So get comfortable with being uncomfortable. And then when you've been doing this for a while, you'll realize it's just part of your everyday.
Well, you hit the nail on the head too, especially if you're not coming from a nursing background. That can be challenging to, just walk up to somebody and say, hey, you're non-compliant. But I think figuring out what their definition or their view of compliance is, golden.
Mhm.
So, and that actually takes us into our next topic, which is rounding on devices in general. So at our facility, twice a week, we're out and we're rounding on any patient with a central line, with a urinary catheter, and we have a bundle of compliance, a short list of things that we want to do to make sure that we're reducing the risk of an infection. So what does device audits look like at your facility, and how have those impacted your patients? Trina, we're going to throw this one out to you first.
Oh, excellent. Thank you. So I've talked to my charge nurse about this. Like, for example, if they need to do like their daily chlorhexidine bathing for their central lines, it'll pop up. I think the note will pop up to do that at shift change, and that's not always the ideal time. So they've come up with a checklist that they'll reference, and they can make sure that they got that done by the end of their shift, because sometimes people get busy, there's more emergent problems, and they want to make sure that they are able to hit that whole checklist, whether it be for, prevent cavities, like if you're assessing the Foley catheter and cleaning that, or if you're intubated and you're trying to prevent pneumonia. There's we have checklists in our ICU, for example, for all those things.
That is great. And you hit on something where maybe it's not the best time for them to go and correct something right away, or maybe it's something low level that it's not going to pose an immediate risk to the patient, but it still has to be addressed.
Mm-hmm.
So Jill, going to you, how do you make that balance with, it's not life-threatening, but it still needs to be done?
Yeah, what we've tried to do with our device surrounding is hit all of our units at least weekly, but also balance this with all of the other rounds that are happening, not just with us, but there's a lot of device rounds that are being pushed through unit leadership, and really trying to talk about life-threatening stuff. What do we want to make sure that the nurses and the units hear and hold on to and really grasp, and how can we make sure that this information gets back to them if they're not present for the round? So we've done a couple things to kind of tweak how we communicate after rounds and during rounds. So we always take the nurse in with us to show them, yeah, it might not be life-threatening that the dressing's starting to pull up and needs change, but it's important. And then we always follow up with an email to unit leadership saying, here's the things that you did great, here's where we have the opportunities. And one of the really cool things that we've gotten really great with the CAUTI rounds is all of the CAUTI or the Foleys that we have identified that can be removed. The CAUTI leadership team will go back 48 hours later and see how many of those got removed based on their recommendations. And we're keeping a compliance metric on that too. And ideally, we'd like to identify 0 that could be removed, because we don't want any in that are unnecessary. So those are some of the metrics that are coming out of our device round, so that, yeah, you have something that you can follow. Because I think all of the nursing leaders want metrics that they can say, well, did we improve? And how do you know? So trying to, put a number around some of these things so we can show them their improvement.
That is great. Deanna, have you seen newer IPs as a program manager? Is that a struggle to train them up for device rounding? Is that a challenge, or is the training process pretty smooth with that?
Truthfully, it's been a little more challenging. We had, I started a new process in the beginning of the year with point prevalence outside of like going to rounding and things like that, where when we take all of our facilities that same week and we look at every single central line and catheter and we're looking at the same questions.
Mhm.
And so we do that point prevalence to really look at what are the trends across the system. And so with that, we did learn that there are some IPs that aren't, especially those that don't have the, even if you are a nurse, you might not have worked in a hospital, you might not have ever worked with central lines or catheters. And so I think there would, as an infection preventionist, there's this assumed thing that, oh, you know how to look at a central line, you know how to look at a catheter, but that's, or a ventilator, and that's not always the case. And so I think there's definitely a gap that we've identified that even if you've worked in the past 20 years or 20 years ago as a nurse, you might not know what that looks like now. And so I think that's definitely a barrier that has been presented working as an infection prevention manager.
I don't think you're alone in that either. The technology changes, the focus changes, and what may have been a KPI last year, maybe it's not this year, and now we've got new things to focus on. And yeah, I think you hit the nail on the head with that. Shifting gears a little bit to a big KPI for a lot of facilities is SSI, and SSI specifically related to colon surgeries. And so a lot of research has been done, and you'll see it on the back of the AGIC magazines, solutions like Nosin or things for nasal decolonization. Jill, are these products, are they having a good outcome? Are we using them? Have we figured out the best way to reduce SSIs with these nasal decolonization products?
It's interesting that you correlate it with the colon SSIs first, because I think there's some question about which service lines are things like nasal decolonization and skin decolonization, which are they most effective in. I think we could spend a whole podcast episode talking about that in general, but I will say that there is a lot of evidence out there for nasal and skin decolonization prior to surgery. Some of the types of cases, like orthopedic cases, there is a lot more evidence that supports the use of such products. So we do use these types of products pre-op, and we do CHG bathing the night before, and it's hard to say like, yes, this is why we're decreasing SSIs or not, because like everybody else in every other HAI, you're not just doing this one thing. And it's hard to isolate nasal decolonization or skin decolonization and say that this is the one change that we made. It's always part of a bundle of things. And the evidence is there. It says as a bundle, it's going to support SSI prevention. But it is hard to say that that one thing is the one thing that's preventing SSIs or not. But we do highly focus on those two types of decolonization.
You hit the nail. Yep, that makes a lot of sense. And it is hard to, because it's a game of inches. One of the spine surgeons who I used to work with said SSIs are so multifactorial, to try to get it down to one key action is almost impossible, but we shoot for the bundle. Trina, in your facility, and especially with your experience in epidemiology, have you seen any large scale approaches that have been more or less effective with surgical site infections?
No, I have not. No, I don't know. I can't point to a specific study. I do know for my Longmont facility, my team tells me, because I'm a novice IP, so I've been at this job just for a few months, that we only do on our total knee and like hip replacements. We're not doing it on fractures, but we're doing the rest of the bundle, like the chlorhexidine bathing pre-op, and you know, obviously having your antibiotics and whatnot. So I can't speak to it maybe as well as others could, but
I like that approach though, of focusing on one procedure type, and especially one where you get a lot of bang for your buck with orthopedic surgeries. So I think that's a good approach and a good way to start in a small way, and then have some data to build it out a little bit. So speaking of needing more data, and this is one we want to throw out for anybody to get your thoughts on. The CDC has proposed some new isolation guidelines related to contact, droplets may be going away. And now we've got contact and airborne isolation. So, Deanna, I'll pick on you to get your thoughts on these new proposed isolations and see what you think.
Yeah, I have some mixed feelings on some of them.
I think we all do.
Yeah, I mean, I think that there's, especially like looking at just, looking back at the last 4 years, I think what we've learned, especially with the CDC changing things, is that team members start to lose trust on what they can, like, you've been hearing the same thing. It's been droplet for how many years, and all of a sudden it's changing. And so now you have these nurses and CNAs and doctors saying, well, if it's not that, like, why are we changing it? And it really, I think one of the biggest struggles is then you start to lose the trust of everything else you're telling them, because, well, you're just going to change it in a few years, or everything's just going to change. And so I think that's, for internally, that's one of the things where I'm trying to figure out, like, the best form of communication of once, if this does go through and we have to change everything, how do we best get them on board with understanding, especially when they've watched things change so much over the last 4 years. Now we have another huge significant change. So that's my input.
And I think we're just now gaining back some of the trust that was lost. Not that it was our fault that trust was lost, and nor am I completely blaming the CDC or anybody else. But COVID was hard on everybody, based on the changing PPE, then changing supplies, changing education every couple of days on whatever new was coming out. And now to change isolation again, we were throwing new things out all the time with COVID and monkeypox coming out. And now to have significant changes like this again, just to reiterate the point, it's a lot for people to take in. This is not an insignificant change. And I just want to make sure that those that are on the committee making the change understand the impact this is going to make on the frontline IPs and leaders who are going to be implementing these changes and trying to keep people safe as we implement, because the confusion of changes like this will lead to things happening and exposures potentially. And so that's what I worry about, is, are we going to be as safe as we implement based on confusion and a learning curve and that kind of thing. So it is a little anxiety inducing when you see proposals like this.
I think so too. I think, and with airborne kind of being spread out into a few different categories, it does make me concerned that the seriousness that we take airborne with will be downgraded. And when we see one type of airborne for a TB case, we may just think, well, that's no different than airborne for flu, So it's definitely one of those situations where you hope it comes out right the first time. We hope we get to educate to it once, and then it stays forever, provided it's good. Trina, you've got kind of a unique perspective from the public health side on this type of stuff. How does this roll out, or how does this impact the larger public health picture?
Not sure, but just to say, just to put it out there to, think about it in a scientific light, we're seeing new information all the time. So policies, we saw public health orders change sometimes every other week. Wear a mask, don't wear a mask during the pandemic. So science is constantly evolving, and it isn't that great because we know more now. So maybe it's come from a place where we've taken some lessons learned from the pandemic, or, other items that, that we've been able to get some subject matter experts together to discuss. And I think that that's good, that things change and that we're constantly learning. And I'm hoping that that's, understandable. And that's just kind of how it is. Like, we've got better technology than we did even 3 months ago, sometimes, depending on what it is. So hopefully people can understand, we can communicate effectively and say, this is the best course of action, and people can understand, and it could be effective in preventing the spread of disease, because that's what we really want to do.
Yep.
It's our main goal.
I like that too. So educate in equal parts the new standard, and that things may change, that it's going to be flexible, and that we have to be flexible with, as new data comes out. Now, since we're already chipping at the CDC a little bit, I do have a question about why NHSN is always down. And every time you try to pull your data out of there, it's always down. Does anybody know why that is? No. Old servers.
I have no idea.
Every week. The flip side of that is it makes a great excuse for your boss when you say, hey, NHSN is down. Numbers will be in next week. Now, in terms of the inpatient clinical side, we're lucky here to have a great team of, they used to call them unit educators. Now they're nursing practice development associates, or NPDAs. And we try to work pretty closely with them when new education comes out, things like isolation. So what does that look like in your facilities, and how have you found best to work with unit educators or NPDAs? Jill, if you want to start us off with that one.
Sure. We have educators in various role names like that. During pandemics and during just normal things, we tend to hold training classes and do more train the trainer type of things. With our serious communicable disease training with high level PPE, we'll do the same thing and make sure that we have those folks, so the ones that would be training others, well trained, have all their questions answered, and then ask them to make sure that they're training and checking off everybody else. And that, I think, is doable for the IPs. We certainly can't train everybody in the facility, but we have to make sure we have super users, and that is just how it has to work. I think it became hard during COVID because everybody was so busy, and every time you had a new protocol, then you had to go retrain. And so I think that's something that we never want to have to go back to. But I think that's a really effective way. We also have shared governance councils that we like to attend. I think that's really effective for anytime IPs can integrate themselves into being part of the team and attend these type of meetings or staff meetings or unit huddles. Anytime you can get in front of the staff and show your face, let yourself be present so that they can ask questions. Anytime you can get tidbits of information out in front of them, I think it's a win. So I would just kind of brainstorm all of the different ways that you can do like 30 seconds of education versus like 30 minutes of education, and do it all of the ways that you can.
That is great. You're just using that redundancy. Deanna, saw you're shaking or nodding your head with shared governance.
Yeah, we have a shared governance. So we have one for our entire system, and then like there's different facilities have shared governances, different like there's like a med-surg shared governance. There's different ones for the different like areas. And so we try to have somebody on each of those ones. And then of course, because that's where you're going to hit a lot of your frontline nurses, and getting from the frontline nurses and hearing from their perspective as to some of their barriers, I think has been really helpful in helping us to make movement there. But I think also looking at different methods of education, because of course we have our educators we work with on some of those bloodborne pathogens and TB and some of those main ones, but obviously there's changes that come up all the time that there's not enough nursing educators or other whatever their terminology is for their titles. But so we have been looking at, things like escape rooms have been a new fad lately. We're able to put everything in there, and I know that's been really helpful. So going to the staff meetings, of course, or different things like that. But I think coming up with new creative ways has been, I'd say the most successful in getting information.
Now, what is an escape room? What is it? I know what an escape room is, but for nursing education, what does that look like?
So, we've called them different things. So, we had some of my team members had set up for what they call the room of errors. And so they went through and set up all of these things, and they had to list off all of the things that they could find wrong in that room. And so they went through and put it in, like, I think there was 40 things I want to say they found. And some of
Wow.
the things, it was quite interesting. Some of the nurses and CNAs, what they had found in the room that we didn't even have on the list, but it's just naturally in some of these rooms. So it was nice to see their creative minds in there. But yeah, we just go through and we had a mannequin in there, and it was all set up exactly how, like, everything you could think of that was wrong, they put it in there. And so we've also partnered with like other like regulatory and other bodies
Mhm.
outside of infection prevention to have it more just an infection prevention, because then you can get more buy-in and support to say, hey, this is a whole area. But then we've also done just infection prevention focus, but it's a fun way for them to be engaged. I mean, even we had a catheter that was above the bladder. We had dependent loops in there and things like that. So you're able to tie the environmental piece of it to the devices and things like that, where it's not just having them click through that online based learning where you're just clicking through 35 slides just to get it done with.
That is awesome. I'm definitely going to steal that idea, and hopefully I remember
Yep.
to give you credit because that's a great idea.
Feel free to reach out. My team has done an awesome job with it.
That is cool. All right, I've got 2 more topics for Hygiene Huddle. We're going to do these rapid fire style. So, first one here, environment of care rounds. What's something that you're always looking for? Trina, you go ahead and go first.
Dust.
Dust, nice. Jill?
Stained ceiling tiles.
That's a good one. All right. Deanna?
I target those bloody glucometers.
Glucometers. That's another good one. That's a good one. I'm a sucker for anything instrument tape. If I see it in a peel pack, it's going to get checked during EOC rounds. All right, and last one here, CLABSI reduction strategies. So what's something you're working on this year that you're excited about for reducing CLABSIs? We'll go backwards. We'll go Deanna.
Oh, that's a great question. I mean, I think part of it was we, as a system, we've started that point prevalence, which we did, last week or 2 weeks ago, and we're actually looking at all of the devices. And so I think for this year, we've actually started to like take a back, instead of just assuming what the problems are, we wanted to really dive deep. And so that's where we're starting right now, is we don't have a project to say, hey, this is what we're doing, because we want to, now we have a meeting soon to analyze that data to say, hey, this is our issue. This is where we're going to go from here. So that's our goal for 2024.
Very cool. I like it. Trina, what about you? CLABSI reduction this year.
We have recently been acquired by Common Spirit. So I'm in the mountain region. We have Colorado, Kansas, and Utah. So I'm on our CLABSI team, and what we've been discussing the last couple of months is having the same document that we're filling out if we have an event for our RCA. So we're streamlining and getting on the same page. We're going to all use this document and make sure we have the same CLABSI bundle items that we're looking at, so we can look at our data moving forward to see if we have any commonalities, which as an epidemiologist makes me very happy. So we can hopefully reduce the CLABSI rates. I love data. And then we have a big push for our blood contamination rates. For our blood culture contamination, we're trying to get below 1%. And we've done that through re-educating all employees who are doing any blood cultures. That's just our ED and then our lab. And then we've reduced our numbers. We haven't had, knock on wood here, a single contamination this month. So we started this in end of January, middle of February, got everybody trained. And our team's doing really good. And I'm hoping that that's also going to, the less bloodstream infections we're going to have, hopefully no CLABSIs this year. So
that is awesome, and a huge accomplishment to have no blood culture contamination. That is awesome. All right, Jill, we'll have you close us out with what you're working on for CLABSIs this year.
Yeah, I'm gonna give one that's probably a little weirder, but it makes me excited because I work a lot with the SSIs, and this one kind of crosses over, but we focus a lot on clean, dry, intact dressings. And one thing that we have found is that a lot of central line dressings are being put on hair. And so we're doing a focus on clipping before central line placement. And that's something that we've really pushed hard in the SSI realm. And so now we're really looking also at the areas in the OR and pre-op that really need to expand their clipping area, because you always are putting in a central line for XYZ surgeries. But also in ICUs, in areas that are putting in central lines, they need to make sure that they're clipping and that they're educated on how to use the clipper, and et cetera, et cetera. So it's a little bit different of a action plan for CLABSI, but to keep those dressings on, you need to have a clean, hairless surface, and the hair just makes it come right off.
Yep. That is such a good one, because it's the little things that are the big things, and giving staff the knowledge and power to just make the change right there for the patient. So awesome. Well, just tons of good information. Like Deanna said, each of these could be a whole bigger discussion. So I want to thank you all for joining us and huddling, and we appreciate it. Thank you.
Thanks so much.